Thank you. Besides what Dr. Mervat introduced me with, I am a very proud student of Dr. Mervat, and I call myself one of her disciples. So Dr. Mervat is a person who made me know what cardiac electrophysiology is. Before it, I never knew anything about this special branch. So thank you, Dr. Mervat, for your continuous effort for us and all our content. Today, I hope it will be a nice journey reviewing pacemaker timing cycles and features. And when we talk about basic timing cycles and features, what we will review today is the basic soul of the pacemaker, the programming of the pacemaker. It's like you are programming a computer and you are giving him orders to do specific things at specific times. So we will rapidly review this. Before we will start with naming of pacemakers. We are all accustomed to the naming of pacemakers like VVI, DDD, AI, and so. So first, we use the first position of the name to describe the chambers which are based. So if I have a ventricular basing device, it's having a V. If it's atrium, it's A. If it's dual, it's D. Atrium and ventricular. The second letter is used for the chamber being sensed. So, either A for atrium, V for ventricle, or D for dual, atrium and ventricle. The tricky third name is used for describing the response to sensing. If it's I, like a VVI, we means when the pacemaker senses an intrinsic electrical activity or a native QRS complex, it will be inhibited. It will inhibit the action of the pacemaker. If it's T, T means triggered. If the pacemaker senses something, it will fire or it will trigger action or basing in the pacemaker. If I have D, it means it do both things. So like in DDD, what's the meaning of DDD? The first D refers to I am basing both the atrium and the ventricle. The second D is referring to I am sensing both the atrium and the ventricle. The third letter is meaning that when I feel electrical activity in the ventricle, I inhibit the ventricular channel. When I feel atrial activity in the atrium, I inhibit the atrial channel. But when I feel atrial activity in the atrium, I trigger a ventricular response. So we have dual response, inhibition and triggering. This will be clear when we review dual chamber timing. The fourth name is used with either R or nothing to describe the ability of the pacemaker to do rate modulation. What's meant by rate modulation is the ability of pacemaker to increase its pacing rate when it senses the increased activity of the patient. The fifth letter, which is not usually used, it's used when we describe multi-site pacing, like in cases when we use CRT, we can use ventricle, which means we are basing the ventricle from both sides. So the CRT, and this is an info sometimes making some confusion. The CRT, if I have a lead in the atrium, a lead in the RV, a lead in the LV, or in the coronary sinus overlying the LV, this device is working in DDD mode. The both ventricular sites are acting as a ventricular site, but I have multi-site of basing, both right ventricle and left ventricle. When we start with the simplest programming of all, when I give the pacemaker the function of VOO, let's review VOO, meaning I am basing the ventricle, I am not sensing, and because I'm not sensing, there is no response. So I have OO in the second and third place. V is I am just basing the ventricle. This simple pacemaker has one function and one function only. This function is to fire an impulse at fixed intervals. So if I program this as pacemaker to fire at 60 beats per minute, every 1 second it will give an impulse. Every 1 second it will give an impulse, regardless of anything happening around the pacemaker. This is the simplest form, and this is a form we will build upon. So to describe to the pacemaker that you need it to fire every second, we use the millisecond conversion. So if I use the pacemaker to fire at rate of 60 beats per minute, I give him an order to fire an impulse every 1000 milliseconds. This 1000 millisecond is called the interval of pacing. or the lower rate interval, the interval between one impulse and the next impulse. So I am basing the pacemaker, putting the pacemaker in the heart, connected to the battery, and just give an impulse, count the time, give another impulse. Whether this impulse will capture the myocardium is another story. If the lead of the pacemaker is put in the good place, it will fire the spike, and this spike will cause depolarization and will cause a QRS complex. So we call this capture. So this spike and capture of the QRS complex. And because this interval is fixed, if the patient has intrinsic activity and this intrinsic activity occurs and the pacemaker spike came on the refractory period of the ventricle, it may not capture. Like in this after third complex, it became after the T, the heart was not refractory, so it responded. And after this complex, it became over the T, and this found the ventricular myocardium refractory, so no QRS complex occurred. And in this case, the pacemaker is not wrong. The pacemaker didn't do anything except what you programmed it for. You just give him the order of continuous pacing at fixed rate every 1000 milliseconds. So it's fine. But because it doesn't see and it can't evaluate the myocardial depolarization and the QRS complex, because this function is inhibited, it doesn't see, and this may cause the impulse to become in the refractory period, and this we call functional non-capture. This year we will use some advanced terms as we review because it's mostly a revision. So some terms may be used like functional non-capture. What's meant by functional non-capture? That it's not the fault of the pacemaker. It just didn't capture because the myocardium was refractory. To avoid this problem and to avoid the impulse getting on top of the T wave, where in some susceptible patients or vulnerable patients, like patients with scar or myopathy, this may induce ventricular arrhythmia, we introduced the sensing function of the pacemaker. We introduced the second letter V. So the pacemaker is pacing the ventricle. This is the first letter. The pacemaker is sensing the ventricle. This is the second letter. And because there is sensing, there is a response to sensing. When the pacemaker senses an impulse, it causes inhibition. What's meant by inhibition? Like here in this lower diagram, the pacemaker fires and it starts counting the same interval like before. If during this interval there is no QRS complex or there is no intrinsic activity, the pacemaker will fire when it reaches the number of the fixed millisecond, as we said, like 1000 millisecond. If the pacemaker starts counting and he sensed a QRS complex, and there is a QRS complex, the heart contracted, the pacemaker will inhibit its impulse, will stop counting, and will start counting from zero. Reset, it will be reset, it will inhibit it and reset. And this defines the inhibitory response, which gives us the letter I in the third position of the naming of the pacemaker. So here we introduced the sensing. It's like a man is sitting inside the pacemaker. This man was just counting and firing every fixed interval. Now this man can see. And if he sees the electrical activity or the QRS complex occurring inside the heart, it will stop counting, it will reset and start counting again and will not fire for these beats. So in this situation, when we discuss this tracing, the first impulse spike followed by a based QRS complex, then spike followed by QRS complex at the interval, the automatic interval or the lower rate interval. Then we have a QRS complex, spontaneous QRS complex. This QRS complex inhibits the pacemaker and the pacemaker starts counting from start and it finishes without finding any QRS complex. So it ends with a spike. And if we measure the interval between the intrinsic QRS complex and the following spike, it's similar to the interval. We call it escape interval here, just a naming after native QRS complex. It's called escape interval. Then we find in the last two beats, the heart is beating on its own. So the pacemaker is inhibited and again inhibited and again inhibited. So the pacemaker is acting beat by beat, beat by beat. It's counting, it's looking. If it finds QRS complex, it stops and starts counting again. So this pacemaker is just have what we call two timing. The first timing is the lower rate interval, and the pacemaker is looking at you during this interval. To avoid anything abnormal, what's meant by anything abnormal? To avoid the pacemaker sensing anything other than the QRS complex, we need to make this sensing period a little bit, we can make a little bit change in this period. What we will make? We will make the first part of the interval like the pacemaker is going blind. It's called a refractory period of the pacemaker. Why is this? To avoid the pacemaker sensing the T wave, or sensing the after depolarization, or sensing its own spike. So after the pacemaker fires, it starts with like becoming blind for a few milliseconds, then it's on again, what we call here the open interval. So this lower rate interval is divided into the first part where there is no sensing, because the pacemaker sensing function is off during this period, and this called refractory period. And if something happened during this period, the pacemaker will not see it. If something happens after this period, the pacemaker is able to see this. So we have ventricular refractory period. And the importance of this is I need to know there is a refractory period where the pacemaker doesn't sense. So here we have based spike, QRS complex, and the pacemaker refractory period. Based spike, pacemaker complex, based refractory period. Then a QRS complex, and this induces the same part as a refractory period where the pacemaker doesn't see anything. If it happens that this QRS complex happens inside the refractory period of the previous complex, it will not be sensed, and the pacemaker is not mistaken, because he was ordered not to sense anything in this first part of the interval, which is the refractory period. As we said, why we use this refractory period? To avoid sensing of something that's not supposed to be sensed, like its own stimulus, the basic QRS complex itself, because it's wide QRS complex, the T wave, or what we call excessive after potential happening due to the pacemaker spike, or the combination of the T wave and after potential. All these things can be felt by the pacemaker, and the pacemaker misinterprets them as a QRS complex, and this will cause inhibition, and this may hurt the patient. So in the first part, after the spike, the pacemaker is not capable of sensing, and we call this refractory period. Then it's ready to see if there is any native QRS complex. So this is what we described. Now we see it in a tracing. We have spike, QRS complex, spike, QRS complex after the interval, spike, QRS complex, then a sensed interval, then another interval. But this second QRS complex, or this PVC, occurred in the refractory period of the previous complex. So the pacemaker doesn't recognize it. So it's counting from this beat, from the third beat to the fifth beat. For the pacemaker, the fourth beat didn't happen. It didn't see it. It didn't happen. The fourth beat didn't occur. It just happened inside the refractory beat. So for the pacemaker, 1, 2, 3, 4 beats. The real fourth beat is not sensed because it came inside the refractory period. And this is very important, because as you advance in troubleshooting and reading pacemaker tracing and answering cases, you'll see that sometimes there is a problem in sensing, and you need to differentiate, is it a real problem, or the pacemaker was right and it was justified not to see this because it happened inside the refractory period. There is a further concept. It's a little bit more difficult, but it's not that difficult, which is this refractory period is divided into two intervals. The first part is called the blanking. The pacemaker is completely blind. It doesn't see anything at all. And the remaining of the refractory period, the pacemaker is able to see, but he ignores. So the net result is that during the total refractory period, the pacemaker doesn't act upon anything. It happens in this type. But the first part of the ventricular refractory period is called the blanking period, where the pacemaker is completely blind. It doesn't see anything at all. And the next part, the unblanked refractory period, the pacemaker can see, but it ignores. What is the importance of this? It's very important, and will become very important, the atrial channel in dual chamber pacemakers, when the pacemaker needs to detect atrial arrhythmias. So when he feels frequent atrial beats in the refractory period, he needs to see them and record them to detect if there is atrial arrhythmia, and the patient needs a special pacemaker feature we call mood switch, as we will discuss later. So this refractory period is divided into a blanket period, the pacemaker doesn't see anything, and unblanket period, the pacemaker see things and ignores them and stores this information for further use. For another example of a single chamber pacemaker, let's take an AI pacemaker. What's meant by AI? The first A is that the pacemaker is pacing the atrium. The second A is pacemaker sensing the atrium. And the third letter is the pacemaker causing inhibition in the atrium. Here, it feels the A wave, so it's reset. The A wave is conducted through the conduction system to the ventricle. Again, the A wave is reset. Here, the A wave didn't occur and the interval ended, so it caused pacing of the B wave, which is conducted to the ventricle. Here again, a B wave based conducted to the ventricle. Here I have a BVC, and remember that BVC will not affect the pacemaker at all because it's a ventricular beat, and we have a atrial pacemaker, so there is no lead in the ventricle. The device doesn't see this beat at all. So for the pacing, it's just counting from this spike to the next spike, which cause atrial pacing and QRS complex, then a sensed B wave with a QRS complex. Now we go to the DDD pacemaker. We finished single chamber pacemakers review, so we'll go to the DDD pacemakers. What's meant by a dual chamber pacemaker or DDD pacemaker? The first D means pacing in both atrium and ventricle. The second D is sensing in both atrium and ventricle. The third D is inhibition and triggering. Inhibition because when the pacemaker feels an impulse inside the atrium, it inhibits the atrial channel. When it feels impulse inside the ventricle, it inhibits the ventricular channels. But when it feels an impulse inside the atrium, it will trigger the ventricular channel, as we will see. So here, the pacemaker in dual chamber, the dual chamber pacemaker can act either pacing the atrium and pacing the ventricle, or pacing the atrium and the B wave is conducted through a normal conduction system, causing native QRS complex, or it's sensing the atrium and it bases the ventricle, or it senses the atrium and senses the ventricle. Atrial basing, A base, V base, or A base, V sense, or A sense, V base, or A sense, V sense. This is the possible combinations that may happen in the ECG of a patient with dual chamber pacemaker. To act in dual chamber pacemakers, we need some intervals, some programming that is needed to be put in the pacemaker to make it act in a dual chamber way. Like the first is the lower rate interval. We get it from the VVI pacemaker. It's the time from the ventricular spike to the next ventricular spike, provided there is no atrial sensing between. So the lowest firing of the pacemaker, the time if the pacemaker is the patient is completely dependent on the pacemaker, it will fire the pacemaker and wait, then fire the atrial spike, then wait and fire the ventricular spike. The refractory period of the ventricle is the same as we described in the VVI. Then we have the very important interval, and which is the link between the atrial channel and the ventricular channel. It's called the AV interval. What's meant by AV interval? AV interval is the triggering or the link between the atrium and the ventricle. When the pacemaker get an atrial beat, it needs to connect it to a ventricular beat. A very important point to know is that when I implant a single chamber pacemaker or VVI to a patient with complete heart block, I just put to the patient a stable pacemaker. His escape pacemaker was slow, was unreliable, and was causing symptoms. So I put the patient an infrahisian pacemaker that's stable and that's reliable and will not cause symptoms with good heart rate. But I didn't correct the problem. But when I implant to the patient with complete heart block a dual chamber pacemaker, it's like I implanted a new AV node for this patient. I regained the connection between the atrium and the ventricle. And this connection is done through the AV delay the atrioventricular interval. When the main order you give to the dual chamber pacemaker and the cause of all these intervals we use is just you give it one order. You need to get every atrial event followed by a ventricular event, whether this atrial event is sensed or based, and this ventricular event is sensed or based. So if the device sense a normal B wave in a patient with normal sinus node function, he will sense the B wave and will start the interval. What's meant by interval? It will count for some time. If this time ends without a QRS complex, the pacemaker will fire the ventricular channel. And I have this, it's like the BR interval in normal hearts. And if the pacemaker didn't sense an atrial event, it will base the ventricular, the atrial channel, causing a B wave. Then he will wait for some time. It's called the AV interval or delay. And if this interval ends without conduction, it will end with a basing in the ventricle to cause a QRS complex. So the net result is an atrial event followed by a ventricular event. If the patient has native conduction in some cases, this B wave will be conducted and the B wave is followed by a QRS complex with a normal BR interval. So the net result is that every atrial event is followed by a ventricular event. Every atrial event is followed by a ventricular event. Every atrial event, like either sensed or based, is followed by a ventricular event, either sensed or based. And this gives us the combination we talked before: A sense, V sense, A sense, V base, A base, V sense, A base, V base. Then in the atrial channel, I have an interval that's called atrial escape interval or the VA interval. We just finished talking about the AV interval, the interval from the atrium, from the B wave to the QRS complex, from the atrial event to the ventricular event. Then I have the VA interval, the interval from the ventricular event to the next atrial event. If I subtracted the AV interval from the lower rate interval, I get this interval. What is the function of this interval? It is the time the device will wait until firing in the atrium. This time is waiting for a new B wave. If this time ends without a native B wave, the pacemaker will fire the basing spike in the atrium, causing atrial basing and getting this new B wave, and then conduct it to the ventricle. So the atrial escape interval or the V interval is the time it will wait from the ventricular event till it base the atrium if no atrial events occur. And we can't control this interval. It's just the division, the difference between the lower rate interval and the AV interval. If I want to change it, I must change either this or this. Then I have a very important interval with a very important implications. And after you do some pacemaker study or some pacemaker work, it will become like a friend to you, which is called PVARP, post ventricular refractory period. Post ventricular atrial refractory period. It's an atrial interval related to the ventricular event. What's meant by this? Here, the pacemaker needs to take one B wave and get a QRS for this B wave. Then it waits for another B wave. So the pacemaker senses the B wave or bases the B wave and wait for the AV interval and then get a QRS complex. And then the pacemaker in the atrial channel is blinded for some time. We give him a refractory arrest for some time. Then it's ready for another B wave. This rest after the QRS complex, we called it atrial refractory period post-ventricular event. The importance of this is to avoid the pacemaker sensing the QRS complex. The atrial channel can sense the QRS complex. QRS complex can be large and cause sensing in the atrial channel. Sometimes there is what we call retrograde conduction. The QRS complex causing a retrograde A wave, and this may be sensed in the pacemaker and causing some problems. It's very similar to AVNRT in cases of dual AV nodal busways. So it enforces our concept of that in dual chamber pacemaker, we implanted a DDD, we implanted a new AV node for the patient. So we get conduction and we might get arrhythmias like AVNRT. So this post-ventricular atrial refractory period, it's like a rest in the atrial channel. The atrial channel has done its work, which is connecting this ventricular event to the atrial event. And this rest starts from sensing or basing the B wave, continue through the AV delay, and after the KRS complex with the B verb. After the B verb ends, the pacemaker is ready to receive new B waves, which he is ready to get them and conduct them to the ventricle and causing a QRS complex. So if it occurred before the end of B verb for the pacemaker, it didn't happen. The pacemaker will record it to assess the atrial rate, because if the atrial rate is too much, it will cause him to switch his mood to act as VVI to avoid following atrial fibrillation. So it's like a rest. The atrial channels needs to take every B wave, conduct it, and cause a QRS complex to follow. Then it takes some rest and it's ready again. This rest is called total atrial refractory period, and it's the sum of atrioventricular interval plus the B verb. This interval is called total atrial refractory period, and is the time the atrium, the device can follow one B wave in this time. If we say that the AV interval is 200 milliseconds and the B verb is 300 milliseconds, 200 plus 300 is 500. So if I say that the TARB is 500, so the maximum rate that the pacemaker can follow the atrium is 120. 50 millisecond is translated to 120 beats per minute. So if the atrial rate is faster than 120, the pacemaker can't follow this device and will be a problem. This is important of B verb to avoid the atrial channel feeling the QRS complex, to avoid sensing the retrograde B wave, and this is an example of a pacemaker acting with these 4 timing cycles we just described. First, let's take it from start. Here we have an atrial pacing followed by paced B wave and the start of AV interval. This interval ended without conduction, so we have a paced spike in the ventricle followed by a paced QRS complex, and this will start the ventricular refractory period and will start the B verb and will start the lower rate interval and will start the atrial escape interval, the VA interval. Here, this VA interval ended without a B wave, so no B wave occurred anytime in this period. So the pacemaker fired a spike in the atrium, and this caused atrial pacing. This atrial pacing started an AV interval that ends without conduction, and we have a ventricular pace with a QRS complex. Here we see in this duration, nothing is sensed. The patient is completely dependent on the pacemaker. So acting A base, V base, all intervals are completed. In this example, after this, we have now on the second QRS complex, which is paced. Now it starts the atrial escape interval. We find that there is a B wave that occurred. So this B wave is sensed, and this B wave will start a new AV delay, which ends without conduction, and we have a spike in the ventricle with a ventricular complex. And we will find that the time between this ventricular complex and the complex before is less than the lower rate interval. So the pacemaker is pacing faster. Why it's pacing faster? Because it's now tracking. It's following the atrial lead. The pacemaker acts as the lower rate you programming, like 60 beats per minute, only if it's pacing both atrium and the ventricle. But remember, the main order you give the pacemaker is to follow the atrium, to regain the patient his sinus control of his rhythm. So if the sinus node increased its rate, it will increase the heart rate. Decrease rate, it will decrease the heart rate. And you don't allow it to decrease below fixed point like 60 beats per minute. But if you have a normal sinus node function with a fast B waves, the pacemaker will follow these waves. And this is a very important observation we have if we have your colleagues, young colleagues who are not experienced with pacemaker, and you have a patient with complete heart block with heart rate about 30, and you implant a dual chamber pacemaker, and the patient get out and they find the patient heart rate is 100, and they ask you, how did you program this device? How much rate do you put? You say 60. How is 60 and the heart rate now is 90 or 100? Because it's tracking, it's following the B wave, and this happens by the AV interval and other intervals we described. Here, now, the pacemaker after the QRS complex, the third complex, it waits, and now it fires an atrial spike. This atrial spike caused AV delay, and now we have a conduction. This conduction abbreviated the AV interval, so it didn't fire in the ventricle. It waited, and after this time, this interval ends, so the pacemaker didn't need to fire because we have a QRS complex, and this initiate BVARB, VRB, ventricular refractory period, lower rate interval, and atrial escape interval. Now we have a BVC, and BVC is a ventricular event. The pacemaker sensed it, and it initiated all this. And here we see a very important point in the pacemaker, a little bit advanced, but it's very important and easy to explain here. This is a BVC, premature ventricular contraction. For the pacemaker can know what BVC is, but for the pacemaker, it's just a ventricular event, follow a ventricular event with no atrial event between. For the pacemaker, this is a BVC. And you need to remember that if you find a pacemaker marking many BVCs, you need to make sure they are true BVCs, because sometimes the pacemaker has problems in sensing the A wave and it will mark them as BVCs while they are not BVCs. But here it's a true BVC. It's a ventricular event following a ventricular event without atrial event between. So for the pacemakers, this is a strange event and it marks at BVC. The BVC, like any other ventricular event, will initiate BVARB, ventricular refractory period, and lower rate interval. And if this atrial escape interval, if this interval ends without B wave, it will fire in the atrium, causing atrial spike, B wave, AV delay, and then basing of the ventricle with a QRS complex. And here we find an atrial extrasystole, and this atrial extrasystole is not sensed because it gets inside the BVARB. So for the pacemaker, it didn't happen, and the pacemaker don't record it. So these are the 4 fundamental cycles. This must be imprinted in your brain, and to understand any pacemaker, we will get more advanced, but these are the most basics. Here, after we start using devices in this manner, we find that we may have a very important problem. What is this important problem? Is that if I have atrial basic with atrial spike, and this atrial spike is big, if the ventricular channel sees this atrial spike, what's meant by sees this atrial spike, feel this electricity, and for the pacemaker, if it sees this electricity, it's just a QRS complex. The pacemaker, any electricity seen above a certain level is interpreted as a QRS complex. So if the pacemaker in the ventricular lead sees the atrial spike and mistakes it for a QRS complex, it will not fire. And this may cause the patient to go into asystole. Like this example, the patient is feeling his atrial spike as a QRS complex and it doesn't fire. And this is called crosstalk. This crosstalk can be fatal. What's meant by crosstalk? The false sensation or the false sensing of the ventricle of an atrial spike and misinterpreting it as a QRS complex. So I need to avoid it. So I add a 5th interval, and this interval is called post-atrial ventricular blanking. What's meant by post-atrial ventricular blanking? That only in case of atrial basing, when the pacemaker fires an atrial spike in the atrium, I make the ventricular channel blind for a few milliseconds. Why? To avoid feeling this spike and to avoid misinterpreting it as a QRS complex and avoid going into asystole, which is very serious for the patient. So this is example. I see the 5th interval, the post-atrial ventricular blanking, occurring only after atrial base, no after atrial sense. And because this crosstalk is very risky and it can cause fatal complications, I cannot risk it being happen even after I put this interval. So I accept that it may happen sometimes, and I put a 6th interval called a ventricular safety basing. What is meant by ventricular safety basing? It also occurs only after atrial basing. I give this very short period of ventricular blanking. The ventricle is completely blind. Then I put a very short interval of about 110 milliseconds, And in this interval, I order the pacemaker. If the ventricular channel feels anything, consider it a crosstalk. Even if it's real QRS complex, even if it's real QRS complex. And what I can do if I felt something in this, you end the AV interval early at this 110 millisecond, and you add an extra impulse inside the ventricle. So if this thing I felt was a QRS complex, this impulse will not do anything. But if this thing I felt was not a QRS complex, this impulse will cause a depolarization in the QRS complex, and the patient didn't go into a systole. And if the QRS complex came after this, you considered it a normal QRS complex, and you don't fire because it's not related to the atrial spike, and it's not a problem. So the fifth and sixth intervals are done just to avoid the problem of crosstalk. What is the problem of crosstalk? It is the possibility of feeling or sensing the atrial spike by the ventricular channel and misinterpreting it as a ventricular event causing the pacemaker to go into asystole. So I add a ventricular blanking in cases of atrial pacing,
صوت عليك ازاي؟
and
سألني
add
ازاي؟
a ventricular safety period also after
هو دي
atrial
جي؟
pacing, because
هو
if
دي جي؟
anything happened in this duration,
هو دي
it
جي
will
هين؟
cause early firing
هو دي
that
جي
will
هين؟
avoid the patient
هو دي
going into asystole. Here we have an example based AV delay, ventricular pacing, no problem. Here I have atrial pacing, and this I have a ventricular sensitive event. The pacemaker felt something here. There is nothing here on the ECG, so it's mostly felt something related to the spike, and this happened in the ventricular safety period. So the pacemaker causing a shorter AV delay and forced another spike. Here I have A base, V base, nothing problem. Here again, I have A base and V sense and this crosstalk because there is nothing on the ECG, and the pacemaker ends it with a shorter AV delay at the end of this period. And you can see this on ECG and tracing like a very short spikes following each other. So you must have atrial pacing for the ventricular safety pacing to work. And then after a very short time, 110 milliseconds in most cases, you find another spike. This is ventricular safety pacing. Like this tracing, I have pacing, and this of course problematic because the pacemaker didn't feel this P wave. It's under sensing. This is a problem of sensing of the pacemaker, and this caused the pacemaker to fire here like it's not felt the QRS complex. So this is atrial spike, and the native QRS was happening here, so it felt the QRS complex. So he misinterpreted everything and caused a safety pacing. This will become much clearer in troubleshooting lectures. So to finish our lecture, another very important topic we'll come to tracking and upper rate response. What's meant by tracking? We just described tracking. It's just the main order of the DDD is to follow atrial events by QRS events. So I put a lower rate. The pacemaker doesn't go below it. If I have a normal sinus node function, the sinus node will increase. And if the patient is exercising or is anxious, it will increase in straight. And this increased sinus rate will drive the heart rate to increase till I reach the point of the total atrial refractory period. Remember, what's the total atrial refractory period? The pacemaker can handle one B wave at a time. One B wave, he gets a QRS complex for this, and he is ready to receive another B wave. This time is the sum of AV interval plus the B verb. This time determines the maximum rate the heart can go after. If I have, for example, a AV delay of 200 and B verb of 300, then I have a total atrial refractory period of 500. 500 is translated to 120 beats per minute. 120 beats per minute. And the lower rate is 60. Anything from 60 to 120, the patient is going after his sinus rate. But if the rate of the sinus node get over 120, like 160 or 140, the pacemaker will sense one B wave and get a QRS complex, and the next B wave will not be felt. And here I will go into what I call a 2-to-1 heart block. Like this example here, I have this B wave conducted QRS complex by AV delay, this is a B varb. If the second B wave, the heart rate is very fast, or the atrial is fast, it's not need to be very fast, just need to be faster than the TARP, and it gets inside the B varb, then this second B wave is not detected, and for the pacemaker nothing happened, and he waits for the next B wave. This B wave will occur and it will not feel the fourth B wave, and at this time the patient will go into 2-to-1 heart block. So the patient really is exercising or is increasing his heart rate and he needs this rate, but suddenly he goes from 120 following his rate to 60 beats per minute just by increase of the sinus rate. And this is not a malfunction of the pacemaker. This is something inherent in the pacemaker. I can't avoid this. Every pacemaker you implant or every dual chamber pacemaker out there has an upper limit. I can control this upper limit. I can decrease this upper limit. I can make the AV delay short. I can make the B varb short. I can make what's called adaptive AV delay, the AV delay that decreases with heart rate. I can make adaptive B varb that decreases with increased heart rate, that allows a faster rate. But any device has a 2-to-1 block rate. You can calculate it by measuring the AV delay and the B varb. So to avoid it, sometimes you need to increase. But this is a basic behavior of the device. You can't avoid this. You can't avoid this, or you can't cancel this. And this may occur and cause the patient symptoms. So as we learned from our prof, Dr. Mervat, especially in young patients, many times you need to get your patient on a treadmill and make him exercise if he's symptomatic, to make sure that the pacemaker is going well with his heart rate and increase and give him the appropriate rate he needs. And this also happens with sensor rate and the rate response when you turn it on in these patients, especially in young patients. So to avoid this happening so suddenly, the previous scenario, it happens suddenly. It goes from 100, 110, 120, just to 60 beats per minute. To avoid this, I need to put something, or I make something that's called upper rate interval. In our example, we make the AV delay 20, 200, the B varb 300, and the TARP is 500, and this maximum rate is 120. I can make the device going at a maximum 110, and I call this 110 upper rate interval. What is meant by upper rate interval? I tell the device, don't go beyond 110 beats per minute. So what will happen when the patient rate increase? Here we have a B wave, AV delay, and the BV delay ends with a QRS complex. Here the B wave comes fast, and outside the B varb it will be sensed. And here's the AV delay ends. But if I put the spike at the end of AV delay, this QRS complex will be faster than 110, than the upper rate interval I give to the device. So although the device is capable, because in this example we put the numbers that make it possible, the device doesn't follow the AV delay. It prolongs the AV delay and cause the impulse to come at the end of the upper rate. In our example, the 110 beat per minute. Then this makes the next B wave comes closer, and to avoid being faster than the upper rate, it will prolong the AV delay more, and this will cause one B wave to get inside the B varb and not sensed, and this followed by the new B wave with a normal AV delay. And this is exactly like the Vinck-Bach behavior. This is called the Vinck-Bach behavior of the pacemaker. What's meant by Vinck-Bach behavior? The AV delay is getting gradually prolonged till one beat is missed, and then the following BR interval or AV delay interval is short. What is the significance of this? Is to avoid sudden 2-to-1 block. But remember, the 2-to-1 block will happen if the rate increased beyond 120. So this is in the stage before the 2-to-1 block rate. It will occur, either it will alarm the patient or make the symptoms less sudden, which may be helpful. But remember, if you want to make this for the patient, better tracking rate. This is another example of the pacemaker Winkbach, the upper rate interval. I can make it program it. It cause prolongation of the AV delay, till one beat is not conducted. Why? Because in Winkbach, the B wave is getting nearer to the QRS complex. The QRS complex are getting closer to each other, and the B wave is getting nearer to the QRS complex till one is getting in the B verb and not sensed, and the following will have a short AV interval with a normal QRS at the end of this AV interval. To finish my rapid review, there are different types of dual chamber pacemakers. The most common is our DDD pacemaker. Another type that's common used is the VDD pacemaker. What's meant by VDD? I have ventricular pacing, sensing in both atrium and ventricle, and both response, triggering and inhibition. The difference from the DDD is that it doesn't base the atrium. So if I have a patient with a normal sinus node dysfunction, the VDD will act exactly as the DDD. It will just follow the atrial impulses and the B waves, and this will not cause a problem. But if the patient goes in sinus node dysfunction, it will act basing just the ventricle like a VVI, not basing the atrium, because it lacks the basing ability of the atrium. DOO, D basing both atrium and ventricle. OO, not sensing, and there is no response to sensing. And this is a mode of just basing. It's similar to VO. Sometimes I use it if I am fearing interference or something, or the patient going on operation. Sometimes I may use this. DDI, it's like a VVI. We will not go into details now. So this is a rapid review, or a very, very rapid review for the pacemaker and timing cycles. I hope it's good. I hope you enjoyed it, and I'm ready for any